Good evening, one and all. I, Ritika Jaiswal, on behalf of Concord Biotech, welcomes all of you in today's scientific webinar. Good evening, one and all. Concord Biotech, the global biotechnology and immunosuppression expert. We are committed to deliver products with global quality standards in the therapy of transplant, nephrology, and rheumatology. Today, Concord Biotech is very pleased and honored to present this webinar. And today we have very, respected, eminent speakers with us. Now, let me take the privilege to introduce our speakers. Dr. Durgesh Srivastav, very warm welcome to you, sir. Dr. Durgesh, he is a consultant rheumatologist. Hello. Yeah, a very warm welcome to Dr. Durgesh. He is a consultant rheumatologist at Lucknow. Then we have our next speaker, Dr. Archana Singh. Hello, ma'am. A very warm welcome to you. She's a consultant rheumatologist at Chandan Hospital, Lucknow. Then we are having our esteemed moderator for today's webinar is Dr. Pooja Dhawan. Very warm welcome to you, ma'am.
Thank you.
Dr. Pooja Dhawan, she has experience in rheumatology from KGMU Lucknow as senior resident and senior research associate. She has present affiliation from Hind Institute of Medical Sciences as professor in Department of Medicine and in charge rheumatology clinic. Her research expertise showcases 24 publications and 14 scientific abstracts. Presently, she is the president of Society for Osteoarthritis Research. So a warm welcome to all our speakers and moderator. So not taking much more time, quickly I'll just hand over the session to Dr. Pooja Dhawan to initiate and take forward this insightful webinar. Thank you so much, ma'am. Thank you, sir.
Thank you, Concord, and the team which is involved in organizing this webinar. And I welcome both the speakers. So we all know the topic of the webinar is on rheumatoid arthritis, an independent risk factor for cardiovascular disease. I'll not be talking about it initially. Probably we'll have a discussion once both the speakers have spoken. So I'll first introduce the first speaker. She is Dr. Archana Singh, and she has done her DM rheumatology and clinical immunology from Madras Medical College, Chennai, after completing her MD in pediatrics from PG Med, New Delhi. And at present, she's a consultant rheumatologist at Chandan Hospital and also runs her independent rheumatology. She has her own private setup for this. And apart from that, she has done quite a bit of teaching and research work, and she has a number of publications to her name. And she's been very active in last few years. She's spoken in number of conferences and participated in number of conferences in various capacities, and also attended number of workshops. So I won't take much of your time. So I invite the first speaker, Dr. Archana Singh, to initiate with the webinar, with the first talk.
Thank you, ma'am. Thank you so much. Start the screen sharing. Hello. Please, can you share the screen? Can you share my?
Ritika ma'am, are you sharing the screen?
Yes. I'm just showing. Can you see?
No. You just open that.
No.
You open the PPT.
Yeah, this. It's not visible. One minute. Is it coming?
No.
No, ma'am.
Yeah.
Can you see mine now? I'll just
Ma'am,
do
can you
it.
see?
Oh, yeah. Now we can see yours. Yeah.
Yeah, please.
Okay.
Yeah.
If you just
Switch to presentation,
Yeah,
please.
please.
can you just expand it? Full screen. Good evening, everyone, respected seniors, colleagues, and colleagues at Concord. Thank you for the opportunity given to me to speak on this topic. Actually, this is one of the less pure spoken topics in routine practice. So I'm glad I was given this opportunity to speak about cardiovascular risk in RA. Usually, we speak about the routine joint activity, and we're done with that. So here, thank you for providing me with this opportunity. So basically, I would like to talk about the role of TNF inhibitors, especially adalimumab, in cardiovascular diseases associated with RA. Next slide, please. So, what is adalimumab? Basically, adalimumab is a TNF inhibitor, which is used extensively in the management of rheumatoid arthritis, and since through its mechanism of action by inhibiting the TNF alpha molecule, it limits the inflammation of vascular inflammation by preventing endothelial activation, endothelial monocyte adhesion, and leakage. So studies have shown that adalimumab can significantly ameliorate dyslipidemia, endothelial dysfunction, carotid atherosclerosis, and arterial stiffness, which is seen in patients with RA, especially the patients who are not on DMARDs, and chronic patients of RA who have prone for this pro-atherogenic mechanisms due to the various mechanisms which are involved in RA, which we'll be seeing in further slides. So basically, in these patients, adalimumab has been shown to reduce or ameliorate dyslipidemia and endothelial dysfunction, carotid atherosclerosis, and arterial stiffness. Thereby, it reduces the risk of cardiovascular damage in patients with RA. Next slide. So here in this slide, this slide is summary of various cytokines which are involved in the pathogenesis of RA and joint destruction. And here we have summarized what function each cytokine performs and how targeting the TNF molecule brings about the various clinical changes which it does. So in this, we can see that basically IL-1, IL-6, TNF, they're the most important cytokines which are targeted in the pathogenesis of RA. And what are the functions these cytokines do? Basically, IL-1, IL-6, and TNF, they're involved in various proportions in leukocyte in bringing about leukocyte adhesion, monocyte, monocyte and macrophage. They enhance the function of monocytes and macrophage and lead to the production of matrix metalloproteinases. Then they also cause plaque destabilization and lead to thrombus formation. Then most importantly, TNF is involved in endothelial dysfunction, so expression of adhesion molecules, production of tissue factors, and production of MMPs. Then there is smooth muscle cell functions which are also altered to accelerate the production of MMPs and lead to cell proliferation. So basically, TNF is one of the most important molecules which is implicated in the pro-arthrogenic mechanisms in cardiovascular disease in RA patients. So what are the molecules which target these cytokines? So basically, methotrexate, we have anakinra which targets IL-1, then we have tocilizumab, sarilumab for IL-6, then we have adalimumab, setrusumab, etanercept, golimumab, infliximab for TNF inhibitors. Then we have the JAK-STAT signaling, which is one of the most important signaling pathways in immunology, and that is being targeted by the use of molecules like baricitinib, filgotinib, tofacitinib, and upadacitinib. Next slide, please. So, what are the clinical evidences and studies in favor of adalimumab being useful in ameliorating cardiovascular disease and risk factors in patients with RA? We'll go through that. So, first study being next slide. So first study being there was a meta-analysis which studied the effect of adalimumab on risk of major adverse cardiovascular events in rheumatoid arthritis. It was basically a meta-analysis of randomized trial, and the objective was to study the effect of adalimumab, which is a TNF inhibitor, in combination with methotrexate, either in combination or alone, on the risk of major adverse cardiovascular events MACE in patients with rheumatoid arthritis. So basically, the meta-analysis included data from individual patients with rheumatoid arthritis, and it was randomized to a double-blind treatment with combination therapy of adalimumab with methotrexate or methotrexate alone in monotherapy in phase 2/3 clinical trials. And then the data was collected and it was analyzed. All patients who received at least one dose of study drugs were included. The primary outcome was the time between baseline to MACE to a cardiovascular event, adverse cardiovascular event, and a composite of non-fatal myocardial infarction, then non-fatal stroke and CV death. These component events were also studied separately. Events were adjudicated by a blinded external panel of 2 cardiologists and 1 neurologist. Times to event were compared between the adalimumab and methotrexate arm, using the Kaplan-Meier estimates of the cumulative risk and the Cox proportional hazard model stratified by the trial. The sequential home procedure was used to account for testing of each MACE component, and multivariate Cox models were also applied. So basically, these were the modalities which were used to compare the 2 arms, patients with different the study outcomes are compared in both the arms, and total then patient was also the baseline data which was collected was baseline age, sex, body mass index, blood pressure, total cholesterol, history of diabetes, history of MI or stroke, and prior use of statins and antihypertensive drugs. Next slide, please. So the results was that a total of 1,411 patients on adalimumab methotrexate combination therapy, as opposed to 1,036 on methotrexate monotherapy, were included in the study, and 64% of these patients were methotrexate naive. So mean age was 53 years, and 74% patients were females in the entire study, and a total of 15 MACE occurred in the adalimumab methotrexate arm, whereas 2 were non-fatal MIs, 2 were non-fatal strokes, and one was a CV death. Whereas 10 occurred in the methotrexate monotherapy arm, 7 were non-fatal MIs, 2 were non-fatal stroke, and 1 was CV death. So basically, compared with the methotrexate monotherapy, adalimumab methotrexate combination therapy was associated with a significant 66% reduction in the hazard of major adverse cardiovascular event. So basically, it was quite significant, and the p-value was 0.04. So basically, this study proved that adalimumab and methotrexate combination therapy showed a statistically significant reduction in major adverse cardiovascular events in patients of rheumatoid arthritis. Next slide, please. So there was another study which studied the effects of adalimumab treatment on vascular disease associated with early rheumatoid arthritis. So this article was published where 8 rheumatoid arthritis patients with a disease duration of less than 1 year received 40 milligram adalimumab subcutaneously every 2 weeks. Ultrasound was used to assess brachial FMD and carotid artery media thickness. Then PWV was determined by arteriography. So these parameters were correlated to C-reactive protein, von Willebrand factor, and immunoglobulin M, rheumatoid factor, and CCP levels, and 28 joint disease activity score. Basically, that's 28 was used to monitor these patients. So the results of this study was adalimumab therapy successfully ameliorated arthritis as it decreased CRP levels and DAS28. So both the p-values were significant. Endothelial function, endothelial dysfunction measured by FMD improved in comparison to the baseline, and there was a carotid intimal thickness was also decreased over 24 weeks, indicating a mean 11.9% significant improvement. So after 24 weeks. So basically, this study also study also shows that treatment with adalimumab exerted favorable effects on disease activity in and endothelial dysfunction in patients treated with in patients of rheumatoid arthritis. Next slide. Now, there was another study where it was around RCT evaluating the effect of adalimumab upon biomarkers of cardiovascular risk in ACPA positive rheumatoid arthritis patients. So, in this study, the RCT was the objective was to evaluate whether adalimumab improves cardiovascular risk biomarkers in patients with anti-CCP positive rheumatoid arthritis and to explore the contribution of known risk factors. So, in this study, 60 patients with 30 established with a moderately high active anti-CCP positive RA were enrolled, and in this the RCT was conducted using Humira versus placebo. So patients underwent assessment of reactive hyperemic index, carotid femoral pulse wave velocity, and disease activity twice before receiving treatment, and then at weeks 1, 4, 12, and 24. Intention to treat analysis compared changes in each treatment arm by t-test. Secondary analysis by random effects, GLS regression modeling was applied, and RHI and PW was applied over RHI and PWV, and it was adjusted for clustering within the individuals. Next slide, please. Next slide.
Yes, ma'am.
So as you can see in this table, the results were that there was no significant difference in treatment arms for RHI, while preliminary analysis suggested that positive shared epitope status was associated with poor endothelial dysfunction rather than for inflammation. CRP, the p-value was 0.379, and for treatment was 0.487. This was not significant after adjustment for clustering. So at weeks 4 and 12, PWV was significantly lower in the ADA arm, and this trend was seen more consistently in patients with recent onset of disease with less than 12 months duration. Secondary analysis in this in RCT showed that most significant effects upon PWV were with the significant p-value and mean arterial pressure was seen where age, mean arterial pressure, and CRP levels. Next slide, please. So the conclusion of the study was that treatment with ADA may improve aortic stiffness and treatment may be more effective in early disease. However, the greater effects are from blood pressure and from from aging than compared to the disease activity alone. So while PWV is clearly influenced by CRP, RHI may be influenced more by the shared epitope status, and further work is needed in this category of patients and the ACP negative category of patients, and in patients with preclinical RA. Next slide, please. So, what's beyond the joints in rheumatoid arthritis and effects of adalimumab on hematological and lipid indices? So, this study They basically studied the effects of adalimumab on hematological, lipid, and inflammatory parameters using data from patients on adalimumab 40 milligram fortnightly from 2 centers in Malaysia. So the mean changes in the laboratory values were assessed from baseline to weeks 4, 12, and 24, and they were compared using the paired t-test and the Wilcoxon's signed rank test. Next slide, please. So the results of the study basically showed that total cholesterol, as you can see here, there was a mean reduction in the in patients. They studied around 18 patients with RA who were in adalimumab 40 milligram fortnightly, and the inflammatory markers ESR, CRP showed significant change as early as week 4 compared to baseline, the p-value of around 0.003 and 0.005, both being significant. And from a baseline high disease activity score using 28 using the DAS 28 of 5.3, there was a steady improvement in the disease activity, and remission was achieved at week 24 with a DAS 28 of around 2.4. The hemoglobin levels improved at week 12, and this was sustained till week 24. As opposed to previous studies, the LDL level significantly decreased at week 12, and the change persisted till week 24. So the total cholesterol showed a similar pattern as the LDL. So as we can see from this table, there was improvement in all the study parameters. Hemoglobin, there was reduction in the acute phase reactants levels, and there was decrease in the disease activity, which was assessed by using the DAS 28 score. Next slide, please. So to conclude my talk, I would like to say that adalimumab therapy in rheumatoid arthritis is associated with significant improvement in anemia, LDL, total cholesterol, inflammatory, and the inflammatory markers. Next slide. So basically, my concluding remarks would be that since TNF molecule is a pro-inflammatory molecule, and it plays an important role in the joint destruction and the various cascade which is involved in the rheumatoid arthritis pathogenesis, and the effect of this molecule is also there in the cardiovascular system. So inhibition of this molecule leads to significant improvement in the cardiovascular parameters, and this should be kept in mind while treating the patients, because RA being a chronic illness, subsequently around 20-30% of patients, the cardiovascular system is involved, and we have to treat the morbid, these cardiovascular aspect also in patients apart from treating the joints. So adalimumab being a good choice for treating the joints as well as for ameliorating the cardiovascular risk factors as well. Thank you.
Thank you, Dr. Archana.
Thank you.
We won't discuss anything at present. We'll take up questions or have a small discussion after the second talk. So I invite the second speaker, Dr. Durgesh Srivastava. Just a brief introduction about him. So he completed his MD in medicine from GSVM Concord. After that, he pursued senior residency in the Department of Rheumatology at KGMU for 4 years, and after that, he joined the DM course in the same institute, which he completed it in July 2017. And basically, he's in private practice in Lucknow and been visiting various hospitals of Lucknow and all the nearby suburb areas. And he has presented number of papers in conferences, and also published 8 articles in various medical international journals. So over to you, Durgesh, to start with your talk.
Thank you for the kind introduction, madam. Good evening, everybody. Can we start the slides, please?
Yes, sir. Yes, sir.
So I thank you all for this opportunity to present my views regarding the cardiovascular risk factors in rheumatoid arthritis due to RA per se. So as we all know that rheumatoid arthritis is a multi-system heterogeneous disorder which targets not only the joints, and as cardiovascular organs are vital organ in the body, we need to keep a check on involvement of these structures and these functions. So next slide, please. So as RA causes multiple extraarticular manifestations, so first let me tell you some of the main extraarticular involvements in RA, as the data show that around 40% of patients of rheumatoid arthritis, they may have extraarticular manifestations. And these manifestations may appear after variable period of disease activity and onset of the disease. Some may occur within 1 or 2 years, and some may take more than 5 to 10 years. And the chronic inflammatory state of RA is responsible for these extraarticular manifestations. And main manifestations include rheumatoid nodules, rheumatoid vasculitis, pulmonary neurological dysfunctions, gastrointestinal side effects, and renal and hematological disorders. Next slide, please. So these manifestations do harm in the way that the patients may become sick with other diseases also, and which may lead to early mortality. And in cardiovascular involvement, the patients may land with myocardial infarctions, congestive heart failure. In the lungs, they may have ILD and bronchiectasis. In gastrointestinal system, there may be increase in liver enzymes, which may be due to the treatment also. And there may be intrahepatic hemorrhage, hepatosplenomegaly. And if patients take treatment without monitoring, they may land up with cirrhosis also. Some cases of pancreatitis and amyloidosis have also been reported. Then neurological involvement is in the form of cervical myelopathy, which is usually a consequence of cervical spondylitis, which is seen commonly with rheumatoid arthritis. And then there may be treatment-related issues, which may be related to TNF-alpha, leading to neuropathies. Renal involvement may be seen as glomerulonephritis, drug-induced nephropathy, and secondary myelaidosis. And finally, few cases of lymphoma have also been reported. Next slide, please. So coming to the main topic here, rheumatoid arthritis patients exhibit around 50 to 70% elevation in the heart disease risk as compared to the general population. And in persons with RA who are above 45 years, this risk is threefold as compared to the general population. And the cardiovascular disease remains the leading cause of death in these patients. The main clinical manifestations, as I discussed, include ischemic heart disease and congestive heart failure. Next slide, please.
Yes, sir.
Next slide, please.
Yes.
So coming to the pathophysiology behind these manifestations, so there may be two pathways. The rheumatoid arthritis may involve coronary arteries, or it may involve cardiac tissue directly also. When the arteries are involved, it is because of endothelial dysfunction, which leads to atherosclerosis and stiffness in the vessels, which leads to plaque formations, leading on to thrombosis and angina, infarction, shock, or arrhythmia, etc. These are ischemic manifestations. And when the disease activity involves the muscles of the heart, it leads to myocarditis or pericarditis, leading to myocardial fibrosis and systolic diastolic dysfunction, leading on to conduction defects and valvular abnormalities, which lead on to dilated cardiomyopathy or inflammatory cardiomyopathy, finally leading to shock and arrhythmia or sudden cardiac death. And these are classified as non-ischemic heart manifestations of rheumatoid Next slide, please. Coming to the basis or basics of the pathophysiology. So the traditional risk factors include diabetes, hyperglycemia, and this leads to oxidation stress in the tissues. Tobacco use is also a major factor in cardiovascular dysfunction, and hypertension, dyslipidemia. These all conditions cause endothelial dysfunction because of oxidative stress and abnormal function of the normal molecules. Because of exposure to free radicals, normal molecules become glycated or oxidated, and they act as harmful oxidative stress producing molecules, which lead on to production of pro-inflammatory cytokine milieu, like increase in the TNF levels, increase in interleukin 1, interleukin 6. Apart from these, some other factors like obesity and chronic kidney disease, they also play a role. And some of the non-modifiable factors like genetic risk with altered background risk of CVD, these also make an environment for pro-inflammatory state. And at the cellular level, there are post-translational modifications of molecules, which lead to formation of autoantibodies like anti-CCP and rheumatoid factor, which antibodies go on to attack the natural tissue. And this leads to dysfunction in the endothelial membrane, endothelial cells, some disruption, swelling, and finally leading on to atherosclerosis and thrombosis. Next slide, please. So while the cytokines are a key player in the inflammatory process, and they contribute to the cardiovascular risk by recruiting immune cells, activating the endothelium, differentiating monocytes, forming foam cells, and causing plaque formation and rupture, leading on to thrombosis. Also, increased level of pro-inflammatory cytokines, which are found in joint space and systemic circulation. And these include TNF, IL-6, IL-17, IL-20, etc. When the disease activity is high, the damage takes place quite quickly, and the duration for manifestations of these symptoms may be reduced. So it is very important that disease activity is kept in check so that these pro-inflammatory molecules are not increased in the blood and the endothelial damage is properly controlled. Next slide, please. Next slide, please.
Yes, sir. Next is this one is next one.
No, this is done.
This is done. Oh, this is the second one.
It's not moving. Yes, it is. So coming to the targeting these disease risk in rheumatoid arthritis, as we know, the main treatment of rheumatoid is with the disease modifying drugs, which is traditional method, and we now have biologic treatments also available with us. And latest are the synthetic targeted treatment. So while we treat the disease, it controls the inflammation, and indirectly the risk of cardiovascular disease is also reduced with treatment. So first we have to target the patient's behavior, like asking them to stop tobacco use if they are using it, and proper control of comorbid diseases like diabetes, hypertension, CKD, etc., and asking them to maintain a proper exercise schedule, avoiding or limiting uh, use of over-the-counter non-steroidal anti-inflammatory drugs or corticosteroids, and then finally potentially selecting the DMRs which have the favorable risk profiles for CVD. Next slide, please. So as this is a slide just to summarize what I have spoken. The traditional risk factors which can be modified include disease activity itself. So treating RA and keeping the disease activity into remission is the primary target. Tobacco use cessation, assessment of CVD risk, aggressively treat dyslipidemia with statins and other drugs, treat comorbid conditions, encourage physical activity, and minimize glucocorticoids and NSAIDs, and using proper DMRs or biologics which have a favorable role in cardiovascular disease in RA patients. Next. So now coming to brief detail about various anti-rheumatic drugs and the CVD risk profile, which has been noted as per the data available with various researchers done. Next. So the primary drugs which are used are NSAIDs, which clearly have a high risk, and the risk ratio is 1:1.18 times more as compared to the placebo. And there is no definite difference between the COX-2 selective versus non-selective drugs. The second group of drugs which are having high risk of CVD is glucocorticoids. Clearly, many of the studies have shown, and the risk ratio is 1.47. The third major and the first majorly used TMRD is methotrexate, and it has been shown in multiple studies to reduce the risk of cardiovascular disease, and the reduction ratio is 0.72 times as compared to the placebo. It reduces not only disease activity of RA, it also promotes cholesterol efflux, improves endothelial function, and reduces the oxidative stress. Other DMRs, there is no definite data to show whether they increase or decrease the risk of cardiovascular disease. However, they are known to reduce the RA disease activity, but no proper impact on cardiovascular function have been noted. Coming to TNF inhibitors, various studies have shown and meta-analysis have shown that the risk of cardiovascular disease is significantly reduced with use of anti-TNF agents, and the reduction is up to 0.7. They reduce disease activity very efficiently in RA. They improve the surrogate markers of cardiovascular disease. They improve the proatherogenic rapid indices, and they have favorable functional lipid alterations. They reduce the oxidative stress and endothelial dysfunction. Coming to other non-TNF biologics, the data is limited regarding their risk profile. And coming to novel synthetic DMARDs like tofacitinib, the data is not much, but recently there have been some warnings, and there is also black box warning regarding long-term use and cardiovascular risk of tofacitinib. So that's about it. Next slide, please. So use of TNF inhibitors in cardiovascular disease risk reduction in RA. As I told that TNF have been shown to reduce disease activity as much as the risk of cardiovascular disease is also reduced. They are highly anti-inflammatory drugs. They reduce the development of atherosclerosis also. And amongst these, adalimumab has been widely used for RA and other autoimmune disorders, and it is a leading therapy worldwide for RA. It limits the inflammation of vascular proliferation by preventing endothelial activation and monocyte adhesion and endothelial leakage. And treatment with TNF inhibitors, it had been also discussed in the previous discussion that TNF inhibitors have a definite role in cardiovascular disease risk reduction. Next slide, please. So a longer treatment duration with TNF inhibitors also seems to reduce the disease risk for cardiovascular disease, and additionally, they increase the HDL cholesterol levels, which is a good cholesterol, which has a cardioprotective effects. The decrease in systemic inflammation caused by TNF inhibitors also improve the HDL efflux capacity and reduces the risk of cardiovascular disease independent of the HDL levels. The systematic review and meta-analysis of estimated 30% reduction in risk of cardiovascular events with TNF inhibitors in rheumatoid arthritis with protective association, especially for myocardial infarction and stroke. Next slide, please. So that's about it. Anti-TNF drugs are proven to reduce the disease activity as much as they reduce the other extraarticular manifestations. Just the concern is the increase in the rate of infections with these drugs, and the cost is a big hindrance. Otherwise, they can really change the life of a patient of rheumatoid if they are freely available.
So thank you, Dr. Durgesh, for your presentation. I think you are traveling at present also. As I mentioned earlier, he visits number of suburb areas around Lucknow. So I think today also he's traveling. And just to summarize, a bit on RA itself a risk factor for cardiovascular disease. So it's already known that RA patients are 1.5 to 2 times at higher risk compared to the normal population for cardiovascular diseases. And the standardized mortality ratio is about 1.13 to 2.98 in patients of RA, and it is where the main cause of death is premature death is cardiovascular disease. And the reason behind this accelerated cardiovascular events is first is disease itself, the inflammation and the cytokines which are released during the disease process. Secondly, these patients are more susceptible to conventional risk factors for cardiovascular disorders. And thirdly, because of the usage of drugs like NSAIDs and corticosteroids. So, yes, we must first of all aim to control the inflammation and achieve remission in patients, and also look for the risk factors, cardiovascular risk factors in all the patients, which I think we don't usually follow in our OPDs. We should screen these patients for conventional cardiovascular risk factors early, and must start the patient on the treatment for prevention of cardiovascular diseases if required. Now, I'll just share a small study which was just published in Indian Journal of Rheumatology, and Dr. Malviya also shared the study in his group. So what they studied about 130 patients of rheumatoid arthritis who were in remission. And they looked for two things in these patients. One was reduced inflammatory risk. So reduced inflammatory risk is where HSCRP is less than 2. As they say that for prevention of cardiovascular diseases, HSCRP should be less than 2 milligram per liter. And the second thing they looked for was reduced cholesterol risk. So for this, what they did was they used the scoring, which is known as the Q risk score, and it's a calculator. Based on that, you can calculate the 10-year risk mortality for patients for for cardiovascular disorders. And why they use this scoring? Because it also includes RA, SLE, and the use of glucocorticoids in the part of its scoring. And based on this Q risk score, they divided the patients into different categories, and according to the risk stratification, they prescribe statins to the patient. And what they found that even though the patients were in remission, still 60 to 70% of patients, they did not fit in the criteria for reduced cholesterol risk or the reduced inflammatory risk. They still had higher CRP, HSCRP, and higher LDL cholesterol. So this is one thing that still we do not look at the atherogenic profile of the patients in our OPDs, which we must look for. We must educate our patients also. And there must be some scoring which can help us to screen the patients. Dr. Malve used this Q risk score. Maybe there are other scores also which can be applied to patients of immune inflammatory disorders. And one more thing that as per the criteria for prevention of atherosclerotic cardiovascular events, the HSCRP should be less than 2. But in the ACR remission criteria for RA, the HSCRP should be less than 10. So there is a discrepancy. Even if the patients are in remission, there is subclinical inflammation which is going on. So that I think that needs to be modified. And probably this is something which will come in time. And this was an input from my side. So I need some inputs from Dr. Durgesh and Dr. Archana also. And if there are any other questions from any audience who has put up any questions on YouTube, which we cannot see, I think the Concord team can help us to answer those questions also. Any input from Dr. Archana and Dr. Durgesh on this aspect?
Yes, ma'am. I think the inflammatory markers, monitoring them is the easiest way to assess and reduce the disease risk for other extraarticular like kidney and heart, because CRP and HSCRP are very, very much also indicator of cardiovascular health. So CRP is an easy target which we can easily modify and screen and target for treatment and change the therapy accordingly.
Okay, anything from you, Archana?
Yes, ma'am. I would I agree with what you said, but one point I want to ask, take your opinion. Like many patients, most of the patients which we see are mostly women over the age of 50 with multiple comorbid factors like obesity, hypertension, diabetes. So initially, when I was a endocrine SR, the American College of Endocrinology had recommended ecosprin AV in all diabetic patients more than 50 years of age. So that was, I think, of late modified that only screen the patient and those because of the risk of bleeding and all. But I feel that I tend to still stick to that practice of adding ecosprin AV 75-10 to patients, even though the screening is okay. Even the lipids are on the higher side, little bit on the higher side. I tend to add that. And maybe you can say I add as a preventive measure because of the subclinical inflammation part, which is always there. So I tend to add this routinely in my practice, ma'am. So do you think it is okay? Like what is your thought?
I think it is okay. See, because the patient profile we see, sometimes we're not able to assess the patients completely. Only clinically we are able to. So if we find risk factors, I think it's always advisable to add ecosprin as a part of prevention to the patients who have some inflammatory disease along with the risk factors, conventional risk factors for cardiovascular disease. Any questions, Sumit, from the audience?
Yeah.
Anybody?
Yeah, ma'am, I think there's no any question, but there's one output, ma'am, there's a new clinical tool came from the International League of the Association of the Rheumatology. So is that any still disease come inside the practical practice, ma'am? Like for the
Which tool?
The tool is, ma'am, still disease activity score, SDAS. Recently,
Still.
yeah, in 2024, it's launched by the clinical research of the International Academy. So
Right,
the school, did you find any still disease in your clinical practice, ma'am?
I still can't get you what you are trying to
Still's
say.
disease, ma'am. Still's disease. Adult onset. He's talking about Still's disease, ma'am. Adult onset AOS.
Okay. Okay. So what do you want to know about that?
Have you seen
Like
any
they
patients?
recently
Pardon?
they launched the clinical tools of the SDAS, means the still disease activity score. Basically, this
Okay.
is for the simple, reliable, and designed for the everyday practice to find out the still disease.
But Still's disease is a completely different disease. We are not talking about Still's disease. We are just talking about rheumatoid arthritis today. So I think that we can, if we someday discuss about Still's disease, so that can be discussed later on, maybe.
Okay. So
So
over
any
to
more
Ritika.
questions? Anything from the audience, or any more inputs from anybody?
That's set for now. And this webinar will be uploaded on the YouTube. So if we get any questions, definitely we are going to connect with the teams.
Okay, fine. Thank you all then. Thank you,
Thank
Dr.
you.
Okay.
Durgesh and Dr. Archana and
Thank
the
you.
Concord team.
Thank you
Yeah,
for
thank you,
watching.
Dr. Thank you so much for the valuable time, Dr. Durgesh, Dr. Pooja, Dr. Archana, and definitely thank you for this, this valuable time you have taken out for Concord and for this insightful webinar. And definitely in future, we'll be connecting with you and we'll be doing much more sessions with you. Thank you for your support, ma'am. Thank you for calling.
Thank you so much.
Bye.
Bye, ma'am. Bye.